And we should be good to go online on YouTube.
All right, hold on. I'm just looking for my right to know. I just had it. I should be able to do that by memory at this point. Jenny, did you send me right to know script for this?
I did. I can resend it to you really quickly.
All right, I've got the minutes.
And just resent everything to you, Senator, and it's the third document down.
There you are. Thank you. Okay, so I have to count. There we go. Great, thanks. All right, welcome everybody. As we said this morning at an earlier commission, just like when you walk onto an airplane and you're sitting there all comfortably, we want to make sure you're on the right plane. So this is the commission to study environmentally triggered chronic illness. And I'm going to start with the right to know script, and then we'll do a roll call of the members. Welcome, I'm Senator Tom Sherman from District 24. Today we'll be conducting a regular meeting for the Commission to study environmentally triggered chronic illness. Before we get started, I'll read through the checklist to ensure that the meeting that we are holding is in compliance with the right to know law. As chair of the Commission to study environmentally triggered chronic illness, I find that due to the state of emergency declared by the governor as a result of COVID-19 pandemic and in accordance with the governor's emergency order number 12 pursuant to executive order 2020-04 and its extensions, this public body is authorized to meet electronically. Please note that there is no physical location to observe and listen contemporaneously to this meeting, which was authorized pursuant to the governor's emergency order. In accordance with the emergency order, I am confirming that, number one, we are providing public access to the meeting by telephone with additional access possible by video or other electronic means. We are utilizing Zoom for this electronic meeting. All members of the commission and selected legislative staff have the ability to communicate contemporaneously in this meeting through this platform. And the public has access to contemporaneously watch and or listen to the meeting on Zoom or YouTube and via phone by following the directions and links provided on the General Court website. Number two, we have provided public notice of the necessary information for accessing the meeting in the Senate calendar. Number three, we are providing a mechanism for the public to alert the public body during the meeting if there are problems with access. If anyone has a problem, please email remote-senate@leg.state.nh.us or call 603-271-6931. Number four, in the event the public is unable to access the meeting, will be adjourned and rescheduled. Number five, please note that all votes taken during this meeting shall be done by roll call vote.
Yep.
Number six, finally, let's start the meeting by taking a roll call attendance. When each member states their presence, please also state where they are and if anyone else is in the room with you during this meeting, which is required under the right to know law. So we'll start with Senator Bradley. Is Senator Bradley on the call? No. Representative Salloway.
Sorry, Senator, I just want to make a quick correction to that. Late last night, Senator Ricciardi was appointed as a replacement to Senator Bradley. So,
okay, is she on the Zoom?
She unfortunately wasn't able to attend today because of the lateness of the appointment. She already had a scheduling conflict for today.
Okay,
but
that's fine. Well, that'd be great.
Representative Salloway is present at his home office in Lee, New Hampshire.
are you alone?
I am alone. Even the
Awesome.
dog won't be with me.
Okay. Representative Woods, if you could state where you are and if you are alone.
I'm in Bow, New Hampshire. I'm in my study at my house. I'm alone in the room, but my wife is someplace else in the house.
Representative Nelson.
Representative Bill Nelson, Carroll County 5. I'm in Brookfield. I am alone. I'm in my home.
Representative McMahon.
Representative McMahon is present. I'm in my home office in Windham, New Hampshire, and my wife may be coming in and out at various times.
Katie Bush.
I'm here in my office in Concord, New Hampshire, alone.
Mike Wimsatt.
Good afternoon. I'm here in my home office in Concord alone.
Robert Timmons. Actually, is he still a member? Yes. Amy Costello.
Hi, I'm here in my home office in Dover with family in the house.
Dan Cizik. Okay. Mindy Mesmer. Margaret DiTullio.
I am here in my office in Jackson and I'm alone.
Hi, Senator Sherman. I
There we go.
was muted,
Oh,
Oh, okay. Hi, Mindy.
but I'm here alone in my house in Rye. There are other people in my home, but not in this room.
Okay. Nancy.
Good morning, everybody. I am present home in Merrimack in a room by myself.
Okay. And I'm State Senator Tom Sherman, and I am home in my room by myself in Rye. So just to give everybody, I think what we should do is do the minutes, but I am going to have to leave as soon as possible because we have an emergency meeting of the Crisis Standards of Care Committee, which I serve on. And Nancy has wonderfully agreed to run the meeting today as acting chair. So do I have a motion to accept the minutes?
so moved.
A
Galloway
second?
moved, yes.
Second,
I'm sorry.
second,
Okay. Representative Soloway moves and Representative Woods seconds. Is there any discussion of the minutes? All right. I will, let me find that again. I will call the roll. Senator Sherman votes yes. Representative Soloway,
Yes,
Representative Woods,
yes,
Representative Nelson,
Yes.
Representative McMahon,
Yes.
Katie Bush,
Yes.
Mike Wimsatt,
Yes.
Amy Costello,
Yes.
Mindy Mesmer,
Yes,
Margaret DiTullio,
Yes,
Nancy Murphy.
Yes,
Okay, did I miss anybody? All right, with that, the last thing that this doesn't require a vote. Typically, we've been doing these meetings, I think it's the third Friday of the month at noon. So that would be March, just setting the next meeting time before I jump. I think that would be March 19th or 17th or something like that.
19th.
March 19th.
March 19th. Is everybody available for March 19th? Same bat time, same bat channel? I'm
Yep.
dating myself when I say that. All right, does that work for you, Nancy?
Yes.
Okay, so let the record show that we'll be meeting 12 to 2 on March 19th. And with that, I'm going to turn this over to the capable hands of Nancy Murphy, and thank you all for your understanding.
Thank you, Senator Sherman. You know what? I noticed Mr. Wimsatt had his hand up. Did you want to say something?
Yeah, I just wanted to, I do have a conflict for the first hour of the meeting on that date, but it's not, I can always join late.
Okay. Does anybody else have a conflict? I'm thinking that that's the meeting where we're probably going to have the presentation from the Department of Education. I think that was the next up on the agenda. And hopefully it'll be taped. Is that all right, Mike? That if you're, maybe we can do the rest of the stuff first and have the presentation a little later in that meeting. Okay, great. The other thing that just in terms of meetings, I know we've been discussing the need to meet as subcommittees. So is that something you think we should talk about now? I know the senator had asked that we review maybe the last 6 meetings or so to come up with some recommendations to see what, where we want to move forward. And I thought it might make sense to have subcommittee meetings before that meeting. Any thoughts?
We ought to do that.
I think we have the education data. Are there any other subcommittees? Yes, Mindy?
So are we able to meet using some sort of Zoom platform? Or there was a question about whether we could physically meet if there was a opportunity to use the Zoom.
Right. Jenny, do you have any answer? I know we asked that at the last meeting. Any updates?
So sorry, I have to admit, I was checking my voicemails while you guys were chatting and
Okay,
listening to a constituent voicemail. So sorry, what's the question?
No worries. We were just wondering, we'd like to be able to have the our subcommittees meet before our March 19th meeting.
Mhm.
And we just didn't know if that was possible yet. We knew there were some scheduling issues, and we sort of important that we meet before them.
Yeah, no, it is absolutely possible. The only constraint that we really have in terms of the Senate Zoom is we only have 3 Senate Zoom accounts, and we are pushing our luck getting one to use for this commission meeting. We have in the past allowed other Zoom accounts to be used to host meetings. So I know Senator Sherman was talking about upgrading his account to potentially use that in the issues that we're dealing with the constraints on our accounts. So I think that's definitely something that we can figure out.
Okay. Yes, Margaret?
Yes, so I don't know.
You're muted now.
I'm sorry. I don't know if it would apply, but I use a HIPAA compliant GoToMeeting for telemedicine. And so if I certainly could make that available to the education subcommittee, if that would be acceptable from a confidential standpoint.
I'm not sure. Yeah, Honorable Mesmer?
I think the issue is, these have to be public meetings. So my question is whether or not personal accounts can be used for a public meeting forum. I mean, I'd be happy to let ours be used too, but.
So if we were to use Senator Sherman's account, it would be posted and there would be a link in the Senate calendar. If in any subcommittee meeting, the link would be posted and the public would have to have access to that. We've had a number of commissions. The Shaw Ship Commission has a link through the UNH platform. So there are other options for us to use. It's just a question of figuring out that. So if the subcommittees want to determine a date and time, and then we can go from there and figuring out what Zoom platform, but they absolutely would have to be accessible by the public and posted in the calendars appropriately.
Okay, so do we want to maybe now see if we can come up with some dates that we can leave with Jenny and she can look into and see if we can actually confirm I think if we don't, we're just going to get further behind and we only have a month to the next meeting. Any consideration for dates for the education subcommittee? Potential dates?
I haven't thought about it. Well, we'll try to get that done this week. Am I muted?
No,
We can hear you.
We can hear you. Okay, what about the data subcommittee?
I would suggest a similar time frame to this meeting, possibly, if it works for people. On a Friday at noon, any of the Fridays between now and then.
Okay, so I know on the 12th, we have the HB 737 commission meeting. Oh, that's from 10 to 12. So would we want to meet after that, or we have the 5th maybe? Dr. Bush?
Yep, either of those work for me.
Is the
Okay, so
12th is the 12th a possibility?
the 12th is a possibility. It's just that we have a HB 737 commission meeting from 10 to 12.
Can
So
we
we
meet at 1?
Yeah, could we maybe meet just 1 to 2? Do you think that would be sufficient?
That works for me.
Great.
Mindy?
Yep.
Okay, so let's see if we can, who else is on that data subcommittee?
Amy. Oh, yeah.
Yeah, and I don't know if Dan is still participating or coming back at some point, right?
Yes, yeah.
Yeah.
Could somebody remind me what subcommittee I'm on?
I'm not
What do you
sure.
mean?
Representative. I don't think the data, and I don't think the education, as far as I know.
Okay.
Do we have another, is there another subcommittee, or is it just the two?
I think we just have the 2.
No
I
idea.
think it's just the 2.
Okay. All right, so maybe Jenny, you could look into that and see if we could do the 12th from 1 to 2.
And I have what I believe are the correct appointees to the subcommittee, if you guys want to review that.
That would be great if you could read those.
So
That'd be great.
for the education subcommittee,
Yes.
based off of what Aaron very graciously put together for me, it's Representative Salloway, Margaret DiTullio, Representative Mooney, who I don't think actually is an appointee anymore.
He's gone.
Representative Woods, Mindy Messmer, and Nancy Murphy.
Okay.
And then for the data, based off of what I have, Nancy Murphy, Dan Tziki, Amy Costello, Dr. Bush, and Mindy Messner.
Yeah, so I think maybe it would be a good idea to review those again, because I think we have new members. Maybe people want to add their names to those.
And maybe it could be at the next meeting on the agenda. If both groups commit to meeting, they can kind of report back to the larger group. And at that point, people can then, volunteer to join one of them. Or if they want to join sooner, I guess, but it's hard to know what you're joining. So I feel like a report out would be helpful. And then people can decide.
And
Either way.
it's an option for GoToMeeting. Jenny, if you want to use a UNH Zoom account, like I think you have from Joe Porter for Shawship, I'm happy to volunteer that.
Thank you. I'll for sure let you know.
Okay. It's really easy for me to set that up.
Dr. Bush?
Yeah, I just wanted to acknowledge that we do have some guests on the line to give our presentation. And so if I had asked them to just hold the first hour really. And so if we can maybe just plan to move to that portion of the agenda. And then if we have other sort of housekeeping that we could come back to that after. I just want to acknowledge their time and potentially limited time today.
Absolutely. Thank you.
Yeah.
Thank you, Dr. Bush. Maybe you could introduce them. Thank you so much for arranging this presentation. I know both our commission and the 737 commission and members of the public are really interested in hearing from them today. So thank you.
Sure. So we're very happy to have some guests here from the Division of Public Health Services, specifically within the maternal child health section. So Suzanne is here. She's a public health nurse and also the birth conditions program coordinator. And Dr. David Laflamme is here. He's an epidemiologist with the program, but also serves as a research assistant professor at the University of New Hampshire in health management and policy and the Institute for Health Policy and Practice. And sorry, Sue, I didn't want to mess up your name. So please feel free to introduce yourself with your full name. I figured rather than mispronounce it, I would let you do that yourself. But here they are now. We can see their faces even. So thank you for promoting them here to a panelist. And so again, they're here from the DPHS Maternal and Child Health Program and are going to talk to us about some of the data and surveillance work that they do related to birth outcomes, birth conditions, and specifically some details around the birth defects registry that they work on. So thank you all. Thank you both for being here today. And I will pass it over. You should have the ability to share your screen and unmute yourselves now to present.
Hi, everyone. My name's Suzanne Beauregard. You can call me Sue. And I am the coordinator for the Birth Defects program.
And hi, I'm David LaFlamme, the state maternal and child health epidemiologist. I see a few familiar faces here. Nice to see some of you again. Jeff, it's been way too long. Amy. I look forward to talking with you today. I think Sue's going to lead us off with some of the slides.
I'm going to go ahead and try to share my screen here.
Here we go. Great. Perfect.
Can everybody see that okay?
Yep.
Wonderful. So we're going to talk a little bit about the birth conditions program and kind of give you an overview also of the maternal and child health section. I have two screens here, so if you see me looking away from you, I'm looking at the presentation.
Sorry to interrupt you. Is it possible to speak up a little bit? It's hard to hear you.
Oh, sure. Is that better? So this is just an overview of what we're going to talk about today. Birth outcomes versus birth defects, history of the program, registry data, and just some fine points at the end, final points. Sorry about that. So this is just an overview of what the maternal and child health surveillance activities are. So maternal and child health, that section sits within the Bureau of Population Health and Community Services and the Division of Public Health Services. And surveillance programs or activities within maternal and child health. Just a overview is what you see here. And the birth defects or birth conditions program falls under the newborn screening programs activities. So we wanted to just kind of give a brief overview of the difference between birth outcomes and birth defects. And you may be thinking that they're both the same thing, but not necessarily. And I'll let David jump in here also to explain birth outcomes a little bit better. But as you see, birth outcomes refer to measures like gestational age, birth weight, and infants born preterm or at low birth weight at term. Do you want to expand on that, David?
Sure. So birth defects or birth conditions, you might hear them called, are essentially a subset of birth outcomes. And the birth outcomes that most people are the most familiar with are just gestational age and birth weight based outcomes. Of course, there are some others, but those are the two primary ones that you see.
Oops, sorry about that. So the birth defects portion of that are usually structural changes. You can either see them or not see them. Things that you could see, such are like the club feet or spina bifida. Some you can't see, such as heart defects, which are fairly common. And they can be, all of the birth defects can be mild or severe. So things about birth defects, how common are they? I think in general, David and I have talked about these are somewhat rare events. If you look at the information, even though every 4.5 minutes a baby is born with a birth defect in the United States, affecting 1 in 33 infants. When you think about annually, that's only 120,000 babies born with a birth defect annually. However, they are very costly, particularly the ones that need surgical corrections, and then over the lifespan, what it takes to help these children is very expensive. Birth defects are also the cause of 1 in every 5 deaths during the first year of life. So in the first year of life, I think it's the leading cause of death.
And Sue, before you move on, I'll just point out, a little bit in terms, I know we're talking about data over time in this discussion. And so the fact that these are structural changes present at birth, they're not always picked up at birth. I just want to point that out because from a data collection standpoint, we don't always know right away at the birth. So some of these we can track on the birth certificate. Others may not show up until significantly later in life.
Exactly. Even some of the heart defects sometimes are not picked up until later, or sometimes they need to be monitored for a few years to see if they actually are a defect or something that is just, a normal part of, the heart development or what have you. As far as the New Hampshire kind of figures, how do we figure in that? So I think this approximately 120,000 babies per year puts that about, I think it was 3% for birth defects. And for New Hampshire, I think we have about 134 million, I think is what we decided was the amount, the population with about 12,000 births a year. And the information from the previous program was about 2.7% is what we have in birth defects annually.
And just I think you were trying to say 1.3 million is the population of New Hampshire, I think is what you were going for. Yeah.
Yes, correct. I misspoke. Oops, pardon me. So what are the causes of birth defects? So we typically talk a lot about maternal factors, places where we can affect some change prior to a pregnancy, so such as substance abuse or certain medications that someone might be on, or, making sure that we're paying attention to infections. I'm sure previously you've heard, in the last several years, the Zika virus, which is a virus that created birth defects. So, we try to pay attention to those things that we can help with. And making sure that, prenatally before mom gets pregnant, they are aware of these things. The other things that can be on the mother side are obesity or uncontrolled diabetes. We talked about certain medications, or sometimes just being, an older mom being pregnant over 34 years old. Usually, you would think of like Down syndrome or the like. Not all birth defects are preventable, though. One of the things that I think the previous program had spent some time on was like a folic acid awareness that can help reduce the likelihood of like a spina bifida, for example. The relationship between environmental exposures and birth defects aren't as clear. We know that some endocrine disrupting chemicals like the BCBs, pesticides are linked to like the nervous system defects and developmental problems. But there's a lot of information that's missing. And same with living near hazardous waste site or exposure to disinfectant byproducts in drinking water can also put you at increased risk of some of those birth defects. However, there just isn't as much information as there is on the maternal side. So more research is needed to really have a better understanding of what the relationships are within the environment. Something that's important to keep in mind is many times we really don't even know what caused the birth defects. So, we're focusing on the things that we're more aware of, but there are at least, and depending on where you look, this 65 to 80%, some articles say 50 to 70, but within the 65 to 80%, those are birth defects that are unknown. And we just talked about some social, behavioral, and environmental factors are linked with abnormal fetal development. And we, as a surveillance system, monitor the prevalence of the defects over time. So just a little background of what the birth conditions program is now and what it was previously. So the BCP was created in 2003 and was located at the Geisel School of Medicine at Dartmouth. And previous to that, prior to 2003, my understanding is that they were getting information just from what was documented through vital records and what they could find through hospital discharge records. Initially, the program was funded for the 10 years, 2003 to 2013, approximately data through the CDC, and they collected birth defects for those years. So I think, as we'll talk about towards the bottom here, they collect data in a 5-year rolling. So even though you see that the birth conditions program initially lost their funding in 2016, they only collected data up to 2013 because it was, 2 to 3 to 5 years back rolling that they were collecting the information on. So again, they lost their funding in 2016. That particular program at Dartmouth ended up closing for that period of time before the Zika virus came along, and we got funding, CDC funding as part of the Zika epidemic. And I came on around that time and we started surveillance activities just related to Zika. So we weren't doing all of the birth defects as the other program had. And so the program's in-house now and under maternal and child health, as we talked previously, and not part of Dartmouth any longer. So once Zika funding ended, which was 2018, I believe, time is going by quickly, the program moved under funding through MCH in the block grant. So we're back to being operational and now collecting the data that the previous program had been collecting, beginning with the year 2018. So as I discussed previously, the data is collected and it's de-identified and it's reported to the NBDPN, which is the National Birth Defects Prevention Network. And they, along with the CDC, kind of oversee that data, and it's collected over rolling 5 years. So we're just starting in 2018, so we don't have the previous years where the program had stopped before. And we may get to that, but we're just trying to start really from scratch and make sure that we're doing this correctly. So our stakeholders are the CDC and the NBDPN, which is the prevention network. Families born with a birth condition, healthcare service providers in the hospitals, which is where we get our information from, and community organizations and DHHS. So the registry data, what is one of its strengths, or many of its strengths? It's population based, so it's all of New Hampshire. It's active, meaning that it's not just, there's many data sources that help us find the information, and we're able to cross-check it, like the birth certificate, and we look at the hospital data. So I actually physically look at records and confirm birth defects at the hospital. We do all the 45 birth defects that are recommended by the NBDPN and the CDC. And there are completeness, there's certain data elements that we collect to make sure that we're collecting that on all babies, and we try to make sure that the data is complete. Prevention and awareness activities previously for the previous program are different than they are right now, where we're only starting to collect data. We only have the previous program's data to know, what the trends were. But right now we're using social media to disseminate monthly messaging around awareness month. So for example, it's February is Heart Month. So we would talk about congenital heart defects on our piece of social media. There's smoking awareness or smoking cessation months. Well, we would talk about, the risks of smoking and being pregnant and, how that can affect the baby. So that's how we're doing our messaging right now. and also connecting families to appropriate programs such as Bureau of Family-Centered Services, such as special medical services or early intervention if the family needs that. David, I don't know if you wanted to mention about our prevention and awareness activities. You know, we had talked about, you know, our state's fairly small and the amount of birth defects that we get are very small. And we don't necessarily, you know, look at what is going on in New Hampshire, but we look at nationally what the trends are because our data is pulled.
Yeah, and is that the next slide in the deck or?
I think yours is the next slide.
Okay. Yeah, there we go. So, you know, we typically refer to things like this as rare events. And while it would be nice to be able to do in-depth studies in New Hampshire, I think there are two limitations that really make that challenging. One is that they're rare events and we don't have the statistical power in terms of the numbers to, you know, do an in-depth analysis of rare events oftentimes. That doesn't mean we're not looking at them. It doesn't mean we're not putting them on a map and we're not tracking them. But you know, it's challenging to do it for that reason. It's also challenging, frankly, because of the human resources, right? So, you know, I was talking to some colleagues on a national call with CDC the other day, and my colleagues from Wyoming come into this little, you know, Zoom breakout room, and there are 8 of them that are in the maternal and child health epidemiology unit, and New Hampshire has me for 4 days a week. So, you know, a lot of states have, you know, especially larger states are able to have more in the way of human resources to go after things like this. So, we're, you know, we are a little bit limited in terms of the workforce as well. So our reporting also focuses more on counts instead of rates because of the small number issue. So when you think about some of the numbers of birth defects, so Sue, what was the number you gave earlier in a year? What might we see in terms of the number of birth defects in New Hampshire? Just to refresh everyone's memory.
So the rate's about 2.7. I mean, we might see, I think, around maybe 300.
Okay.
And
so the thing to remember is that those aren't 300 that are all the same defect, right? So you still have to slice that up by the type of defect, and there are many types. So our number isn't 300 that we're working with, really. If you're trying to do an in-depth study, it's often much smaller than that. So so we do, you know, some internal analysis where we are doing some mapping and such. Oftentimes, because of the small numbers, we're not able to make those things public, but it's still useful to us. So you should know that, you know, we're looking at these things, we're watching them, and we're tracking them and reacting to them. It's just not everything can be made public because of the confidentiality reasons. So, but there are some things that are. So when we pool data, for example, the 5-year data reports that Suzanne was referring to, you know, those counts are statewide 5 years. So there's no reason we can't put those numbers out, and we have put those out in the past. We contribute de-identified records to the national data set, and to me, that's one of the most important things that we can do. So the benefit to New Hampshire is that the studies that we can't do because of our small numbers get done with that larger pooled data from various states. So it's de-identified, so we don't have to worry about risks there, but the learning comes from those studies, from contributing to those. So when Sue talks about birth defects, is it week or month? But messaging around that, a lot of those messages come from the research that's done with these pooled data. So to me, that's one of the best places that we can act on prevention of birth defects and understanding what's happening is using that pool data, the national data, with who have, you know, CDC has teams of people working on this, and we can really learn from that. So we benefit not only from greater numbers, but also from the expertise of their increase in human resources, right? Some other sources of data that are good for you to know about. PRAM stands for the Pregnancy Risk Assessment Monitoring System. It's a survey of women who have given birth in New Hampshire. We sample, it's a little over 1,000 women a year. The response rate varies from year to year, but it's women who gave birth within the last year. And we ask questions about prenatally, perinatally, and postpartum. And so we've had that ongoing for several years now. And you can find a lot of good reports, including just tables of data in addition to more in-depth reports on the DHHS webpage for PRAMS. If you search PRAMS New Hampshire, that'll come up pretty quick. There's a main page and then there's a publications page. Make sure you go to the publications page. The birth certificate and death certificate from Vital Records, which is over with the Department of State, of course, in New Hampshire. I think we're the only state like that. Those provide some information, and we do have good access to those. There's the all-payer claims data and hospital discharges that we also look at. And then finally, in terms of data, Sue referenced Zika earlier. So emerging and potential issues. So sometimes, we don't know until we're in something that there's more information needed. So with Zika, the example would be, we wanted to know travel status, and we didn't have a way of doing that. Well, we now have some better ways developed of doing those things very quickly, where we can, literally overnight, we can get a question or two out there connected to Vital Records, where we can start asking for some information like that. So when COVID hit, for example, we moved some questions related to opioids off of the birth certificate and put COVID questions on the birth certificate and the death certificate they're temporary, so that we could very quickly start getting some information for that. So that's really helping us a lot. We're also looking at, based on some of the maternal death data that we've looked at, we're looking at some harm reduction things. So, was there documentation of discussion about naloxone or Narcan if a mom who gave birth if there was some prenatal substance exposure reported, for example. So those are the kinds of things that we can sort of do a lot better than we could several years ago. I started back in 2003 in this role, and in the last 3 to 4 years, we've really made great strides. I know you had a presentation last month, I think it was, or last meeting, from some colleagues, Andrew Chalsma, David Wieters, and others, about the new data infrastructure and the enterprise business intelligence, and that's certainly benefiting us as well, and that we're able to not only access, but prepare and present and analyze, especially visual analytics, so much better than we used to be able to. So that project's having an impact on the work that we do also. So Sue and I went back and forth trying to figure out, what is it this committee would like to know from us? So I hope that this overview gives you a sense of what's happening and what can be done. But if we haven't hit on the things that you're interested in, please, let us know, ask us questions.
I think one of the things that I would add too, with regards to the birth defects registry, I mentioned that, we collect information on the 45 birth defects that the CDC and the network request of us. They recommend those. That's part of our RSA. So we don't change any of that. We go by what they ask us to collect on. And that helps with that data that David was talking about, the pooled data. All the states that are collecting data are collecting the same information, so that the information, makes sense for everyone. So we're all, we're collecting Massachusetts. I mean, everyone has different laws, and Massachusetts might collect a few more things based on whatever their laws say that they can. But, for us, that's how ours is written, is we go off on the recommendations of what the CDC and the Birth Defects Prevention Network recommend that we do. Please ask questions.
Rep. Salary.
Dr. Laflamme, quick question. You've indicated that one of the difficulties in getting a data set that you can really work with is the small numbers. You've also indicated, I think very cleverly, that you can get bigger data sets by aggregating data over time. And secondly, certainly by participating in the federal database. Is there any effort being put together to regionalize a database? That is, to work conjointly with Maine, Vermont, and Massachusetts to create a regional database which might speak to regional environmental risks?
I'm not aware of any effort like that. I've heard rumblings about it over the years. We've heard ideas like that come up in a variety of contexts, including birth defects, but not just birth defects. But I'm not aware of that. I would say also that aggregating data over years, I think typically has sort of a shelf life in terms of how many years you should put together before you start hiding what's actually going on, because things change over the years. So being able to know, what's happening over time can be challenging. Dr. Woods? Oh, sorry, I'm not sure I'm supposed to do that.
I noticed that this is an opt-out program, and in other venues, our committee, the committee I'm on, and Dr. Soloway as well, with vaccines, we're wrestling with this opt-in, opt-out situation. Has that dimension been a problem for your data collection at all, either in terms of numbers or administration of the opt-in, opt-out aspect?
My understanding from the previous program is that they didn't feel as though the numbers were large enough to make a difference with that. And I don't remember what the opt-out rate was. That was before my time. Currently, I haven't had anybody opt out that I've sent out, but yes, they can decide whether or not they want to be part of the registry. And they're sent information, once we've confirmed a birth defect, and they're asked, would you like to be part of the registry or not? And if they don't want to be, then we don't use that data. And that's for confirmed birth defects. I don't know if that answers your question.
Representative Nelson?
Thank you. My question is, I don't know, does the dad's history fit into all of this? For example, if the dad was, if known, the dad, their drug use or whatever, I don't know if that's part of the cause of birth defects or the age of dad, etc.
So for the previous birth defects program and for this one, so they do age of dad, age of mom and dad, and its race and ethnicity that are also broken out. So it's being looked at, but I haven't had anything that says specifically we need to target dads on whatever is happening. But it is something that age of dad is collected.
Honorable Mesmer?
So I was looking at the list of birth defects that are on the report, the NBDS, National Birth Defects Registry report. Do you collect, I assume you would, as part of the Zika program, head circumference and body weight, birth weight? And do those, were those previously collected during the initial grant funding back in 2003? And do you surveil that data?
I can take that one, Sue, if you want. So I'm not sure if you meant to say birth weight or not. Birth weight and gestational age are both on the birth certificate for a long time, so that has not changed. But the two new things that we put on there as a result of the Zika surveillance were head circumference and gestational length, not in weeks, but the length of the infant.
Right. So I guess my question is, do you surveil that data to see if there are potential trends in certain areas of the state?
So as far as the birth defects registry, there are data elements that are required that we do, but we don't report that. We report whatever it is that they're looking for the data elements. So we have the information from the previous program. So I know gestational age and length and head circumference, and those are just parts of, what we want to know about the baby. But with regards to the birth defect itself, that's not something that is aggregate data that goes out. It's primarily, the birth defect, the race, ethnicity, mom age, dad age.
So can I have a follow-up question? So particularly with respect to low birth weight or to birth weight, do you surveil that information periodically on a yearly basis in a sense to look at geospatial trends for that information across the state? Are you able to do that?
Yes. Yes to both questions.
Okay, thank you.
Yes, we can, and yes, we do.
And do you report that data anywhere? Or?
Yeah, typically now that's going to an online format. So that would be part of Wisdom, for example, if you're familiar with that system. Yeah.
Thank you. And just as an aside, that's not part of the birth defects registry. That's something different.
Representative Nelson, your hand up to ask a question, or is that up from last time? Okay.
Last time, sorry.
No worries. I have a question actually myself. I'm wondering if there's a mechanism in place for documentation of data on birth defects not immediately recognized at birth. I mean, is that from pediatricians, or how does that information come to you?
Well, that's part of the rolling years too. So for example, if I'm requesting information from a given hospital for the birth defects that we monitor for these years, and baby didn't show up in 2016, but it was discovered that it had a heart defect in 2018, I would find it in 2018 because that's when it was found. So baby's 2 years old, or however old it is. That baby might be 4, but I see it because of the year that I asked for.
Okay, thank you. And actually I have one more. Am I correct that the data on babies born with birth defects outside of here, so just say I'm thinking Boston, may not be available to the registry? Is that true?
Possible. I mean, we might find it through the birth certificate. Correct me if I'm wrong, David, but I think that's probably where we would find it. We don't have any relationships with Boston Children's or Maternal Children's for residents who had a high-risk pregnancy whose baby was born there.
Right. So for vital records, so if it's a birth or death certificate that might have that information on it, we will get that eventually if they're a New Hampshire resident receiving care out of state. If they were born or died out of state. For prenatal care, for example, we wouldn't get those records.
There's an outside chance that in this previous scenario that you asked about, so baby was born out of state in whatever 2013 and 2018 went to a hospital for the heart defect that it was born with, but we didn't know about. I might find it that way. So if they went to a local hospital, then I'd find out, oh, we have a resident that I didn't realize, that they delivered out of state. So that's another way to find it, but it's not that we're going to find them all that way. I mean, what we don't know until it pops up.
Thank you.
I'll add something on the cross-border issue. That's a great question. About 10% of our births in New Hampshire happen out of state, and mainly for 2 reasons. One is that we're population dense on the southern tier, so it's just more convenient to go right across the border. But the second reason is typically a high-risk pregnancy. So they're maybe going to Boston for specialty care where some of these kids might be found, right? So this is also an issue with our maternal mortality work. And so with some CDC funding, we designated a part of that over the past year to have the UNH Health Law team look into cross-border data sharing issues. And I think that work will end up informing some of the work that we're doing with birth conditions as well, to sort of figure out, where does the authority come from? What are the barriers, and if there are any, and how do we go about getting data when there's care perhaps in both states? How do we get all of that? So we're actively working on that issue, really leading the way in the country for that.
Thank you. Representative Woods?
Yes, I'm, as I had mentioned at the outset, I have another commission I've got to bounce out on, and I'll wait to hear from Representative Soloway relative to our subcommittee, relative to that. And then finally, sort of a philosophical musing at the end. Nearing 80, I would consider aging a birth defect.
Thank you.
We'll add that to the list.
See you later, Gary. Other questions? Ms. Costello.
Hi, David, this is not a plant, but is it possible for this group to have a copy of what is collected on the prams
Yeah, that's on the website.
Is it? Okay.
Yeah, absolutely. So the questionnaires, they change slightly over the course of, I think we're on the second version, so there's only a couple of versions there, but the questionnaire that we use is there. That's the best way to get a feel for what's in the data set. But there are also data tables with, percentages, confidence intervals, counts, all that on the website. So we do pretty well at keeping up with that. And the 2019 PRAMS data just dropped. We just got that back from CDC. They do the weighting. It's a complex sample survey, so it takes a little work to do the weighting and then to do the analysis that we do as well.
Follow on, if I may.
Sure, Ms. Costello.
Is the PRAMS fairly consistent year to year?
Well, I mean, things change year to year, right? So for example, the percentage of women falling off of health insurance after the birth, that changed a lot when ACA came on, and we saw a big difference there. So we actually have a data brief about that on the website. But in terms of if a metric is truly staying the same over the years,
Yes.
yeah, PRAMS is pretty good at keeping that fairly steady.
Thank you.
Sure.
Any other questions for our presenters?
This was really helpful. I just wanted to offer a comment that the data subcommittee is going to be meeting again in mid-March, and we may have some more questions, Suzanne and David, after that meeting too. We can reserve the right to pick your brains again.
Always happy to talk data.
Great.
That's a good point. Thank you, Amy. Well, thank you so much, Sue and Dr. Laflamme, for your excellent presentation. And all the data and surveillance work that you do certainly helped us to have a better understanding of birth defects and birth outcomes in New Hampshire. But as Amy said, I think we'll certainly have some more questions when we start to, look at our own goals within the commission. So I thank you both for being here today. We appreciate it.
Happy to be here.
Thank you for having us.
Yeah, thanks so much.
Bye.
That oops, that was helpful. I know we were all sort of looking forward to this, and I know we're wondering also about the special ed impacts. I think that would be the last presentation that we're going to have. I don't know if Jenny has Dr. Senator Sherman discussed that with you, potentially setting that up.
The Department of Education presentation?
Yes.
Yes, he and I have chatted about it. So he's hoping to kind of narrow in the focus on who we're looking to have present over the course of the next coming weeks and going from there.
Great. I think, was there any other presentations that we were looking to have, or was that the last one that had come up in conversation during our subcommittee meetings?
It was the last one I was aware of.
I think so as well. Well, we may have a shorter meeting. We have a bit of scheduling things to discuss, but otherwise, I think we sort of got to everything in terms of the agenda. Any further discussion about anything that we need to talk about before our next meeting? Rep. Salway?
Just an observation.
Sure.
I'm hearing Dr. Laflamme talk about limitations on data. And I understand what he's saying about aggregating over time. I like the idea of aggregating regionally. I would point out in addition that we have several commissions operating simultaneously, one of which is the Commission on Rare Diseases. And that database on rare diseases probably should work integral with the data on birth defects. And what we're looking at is outcomes. And I think that given our experience, especially with PFAS, and I'm assuming that Representative Messmer is hearing me say this, especially when we look at a risk factor like PFAS, we really need to find a way to be aggregating data across diagnoses, across outcomes, rather than concentrating on outcomes. That's just a philosophical observation.
Are you on that commission? Sorry,
No.
excuse me.
No, they were smart enough to keep me off.
But I will say that Sai Charala, who oversees the Bureau of
Yeah,
Population Health
yeah.
and Community Services, where maternal children sit, she serves on that commission. So she both has her hand in the Rare Disease Registry as well as the Birth Defects Registry. So she, at least from a leadership perspective at the health department, is involved in both.
Ms. Costello.
Katie, is it possible to get a synopsis of where that commission is?
Yeah, I think that would be interesting.
From Sai. I want to be respectful of the number of presentations that we're asking from the Department of Health in the middle of a pandemic.
Right, and so maybe there's someone else, maybe that, I don't know.
Someone that could provide a
that
synopsis and
commission.
timeline about where that's going. I think that's a really good point, Representative Soloway.
Mm-hmm. I can certainly ask on my end, but maybe if any of you are connected to other members of that commission, like Amy said, rather than lean on the health department staff, if there's someone else who serves on that commission who could give a presentation, that might be worthwhile.
We know who else sits on that commission?
I believe Senator Rosenwald does.
You know, to be honest, I've been thinking a lot about, the surveillance. It's challenging. And like they said today, we have such rare numbers. We're unlikely to have enough statistical power to see a signal in New Hampshire, probably even to see a signal in New England. That's why contributing to these national databases is so meaningful. And I do wonder, as we think about future agenda items, I feel like there's some work to do to prioritize, right? So what do we want to conduct surveillance on? Where are the real gaps? And should part of our work here be to help prioritize those gaps or identify those gaps and then prioritize the follow-up work, right? So is the priority PFAS and related outcomes? And do we think that's a gap, or is it other neurodevelopmental outcomes? I feel like we've been a little bit stuck, I think, in that there's a whole big world of environmental health related outcomes. And if we could narrow our scope, then we might make some progress towards a specific goal. So I just keep coming back to, how can this group help clarify priorities for environmental health in New Hampshire?
Honorable Mesmer.
I guess one of the things that really was a bit shocking to me today was the paucity of data that exists on, this is something that we all really ought to, the children, the impact on our children in the state is what is the most critical issue, in my opinion, to be tracking. And to see that, no offense to the presenters whatsoever, but the funding that was supporting some of that work comes and goes, and that affects what's being collected and sort of who's looking over that. And that to me is just like a shocking recognition of a problem that, and connecting that to things like special needs, educational outcomes in the end. I mean, the cost associated with that kind of, with birth outcomes that could be prevented is just, it's shocking to me to see that, that has happened over time. And, if there's an effort that we can make to go back and recollect some of that older data to try to put it to use and try, as, just the legislators here, if we can figure out ways to make sure that kind of activity is funded in our state, it is very critical, in my opinion, to do that.
Ms. Costello?
And Mindy, just to clarify, are you speaking about the lack of funding for MCH activities, like when David compared New Mexico with New Hampshire?
Yeah, and the break in time where we weren't collecting or reporting that data. I mean, I looked at the national site, the NBD, whatever it's called, PD, and it says New Hampshire is not collecting data. I know they are now, but it's, so that is just, it's kind of shocking that the funding needs to be consistent, and we need to really prioritize the health of our children in this state for the future, especially with respect to environmental exposures, where we know they're especially vulnerable to the effects of those exposures with lead, arsenic,
Yeah.
the things, the list goes on. So I know Representative Soloway is dying to say something here.
Well,
yeah, but the funding is what I was talking about.
I want to build on your work, but you just brought up, I think, what is the most significant example that we ought to build on. So when we discovered that there were outcomes of lead toxicity, okay, our indicator was the outcomes. We then engaged in a serum testing program for children under a year old that enabled us to identify risks and exposures prior to outcomes.
Mm-hmm.
So I think relying on outcomes as your measure of the effectiveness of your program is short-sighted. That we have to start looking at exposures. Now go back to your own work on PFAS, and it becomes essential for us to monitor PFAS exposures at all age levels, because the outcomes may come much later, but we've got to know that the exposures are there. Okay, I'll be quiet.
Oh, thank you, Representative Salaway. I totally agree. And I think I know people in PFAS impacted communities like ours feel the same way, that there has to be monitoring. We're looking at, generations now of families that are exposed and with ongoing exposure. And I know citizens have concerns about health impacts that we think we're seeing, but I totally agree. I think this is one of the great things about the data subcommittee. I know we're looking to identify what Katie made a great point. We've got to sort of narrow it down, but I think we know. I think it's become clear to us some of those factors that we really have to focus on. Mr. Wimsatt?
Yeah, I have a question, and as kind of an arm's length observer of, hearing now and learning over the last few years about a lot of these various data collection and health outcome reporting programs. They all seem to be separate. They all seem to be very vulnerable to funding lapses and that sort of thing. And I'm thinking, aren't those programs all getting information from the same group of people? It's physicians and doctors' offices and hospitals. I'm wondering, and again, I don't know because I am so arm's length on these things, but has there ever been an effort to sort of centralize that data collection so that, if you're a hospital or a provider, you've got this menu of conditions or diagnoses or whatever it is that you need to report to a central reporting agency or organization every week or every month or whatever frequency it is, so that, and then maybe, the cost of it could come down, and maybe those individual things would be less vulnerable to lapses in funding. So maybe even if, like, for instance, the birth defects program, the folks who process that data and collect it and manipulate it and try to act on it, maybe they don't get funded for a few years, but the data would still be being collected. So when they came around again, they wouldn't have lost 5 years of data like Mindy was talking about. And I'm just asking, it's probably beyond the purview of this committee, but it just seems, to have each of these things subject to the grant, an individual grant, just seems really inefficient and really, kind of treacherous, because it's clearly going to happen. I mean, we experience this all the time. Grants that you get for 20 years, all of a sudden you don't get them for a few years. That happened with our Apple Tree grant. And so, to the extent that this could be somehow centralized so that you don't have it so vulnerable. Is anyone looking at that?
Oh, excellent point. Ms. Mesmer?
Oh, I was going to suggest something else. We can continue on this, but I think that was what we came out of last meeting. At least I did, was the efforts to centralize data collection under the EBC program would be really beneficial for all of these programs. But I do know, they're specifically tied with their blinders on to do certain things that grants allow them to do. But so that's why I called on the legislators who are listening here to, try to support some of these measures to continue the funding on some of these things throughout. So there's no breaks in the funding, or, be open to allowing that kind of funding to be passed on to the budgets. But the other thing I was going to say, and Rep. Soloway may be able to weigh in here, but the first year of this commission, we had a presentation by Professor Robert Woodward from UNH. Since that time, he's actually been part of some really important work that has looked at arsenic exposure in children and the impacts of that, the cost, and how they assess the quality of life, the quality of years moving forward. And I was wondering if that wouldn't be another good idea to have him come back and talk about that, especially while we're talking about this. He's really made that group was really supportive, was actually why the arsenic standard, I think, passed through the legislature, because that was very compelling work on the cost of inaction, basically, with respect to our children. So maybe we could ask him to come back if people are willing.
Great suggestion. Rep. Salloway?
We live in a state where privacy is a very important value. But I think that the world has changed. I'm a great believer in protection of privacy. I don't have a what do you call it? An easy pass. Don't want people to know where I'm driving, how fast I'm driving. It's my personal decision. So I like the idea of protecting privacy. However, as we take a look at the sheer number of environmental risks that are out there, and now the sheer number of infectious disease risks that are out there, I think it's absolutely imperative that we have consistent, reliable reporting, certainly of outcomes and possibly of risk factors. And that's something that we as legislators can mandate. You know, we've done it with lead. And I think it may be time to say this is more important than privacy.
Ms. Costello?
I would second that motion if it were a motion. And also I think I'm optimistic about, under the current administration, that there may be opportunities to build public health data infrastructure going forward. And as that comes forward, to support that movement through Governor and Council, I would anticipate money for both public health infrastructure, but the data infrastructure as well.
Federal money, right? You're talking about?
Yes, yeah.
A recommendation for that could come out of this commission.
To watch for it, or to
make it up?
To write the legislation to mandate data collection.
Yeah, I guess I was speaking more to, as federal monies become available. Are you suggesting to write state legislation related to federal?
No, writing state legislation saying that, we have to, people have to participate in reporting birth outcomes.
Oh, I see.
There's no opt-out.
Huh.
You got to report. Physicians have to report. Hospitals have to report. Has to be reported. We've done that with lead.
Yeah, I think there's probably systems that are getting it. So maybe we're speaking about the same thing, but creating registries for everything may not be the right avenue. It's incredibly time consuming, but in some way being able to get more information, either from hospital discharge, claims, electronic medical record in a timely way, it might allow you to get more than one condition at a time. But just to clarify, my point was really about, to watch for the opportunities around federal funding for public health data infrastructure, and wherever we can, to be able to support its expedient reception at the state.
Rep. Nelson, did you have something you wanted to ask or suggest? Yep.
No, I'm curious. I'm using arsenic and lead as a source. Do they collect data prior to a pregnancy? The data, or the person had the lead, for example, before they got pregnant, or they're having it while they're pregnant? And does the lead exposure, whatever, of the dad, mom's been good, she's lived somewhere else on bottled water and it's good, but the dad drinks all this stuff. Is there a factor that checks on dad to see how that could affect sperm, the whole 9 yards.
Representative Nelson, they don't check that. That data comes in on blood tests that's done on children.
Okay.
I think that's the only data.
I'm not sure that there's a lot of evidence to suggest that high levels of lead in a dad would lead to birth outcomes or developmental delays. I think we know that lead can pass through the placenta. It can also pass through the blood-brain barrier. It's also, if it's stored in the bones, actually during pregnancy of the mother, can actually get pulled out. And because it mimics calcium, the way it's stored in bones can also then get pulled out of bones and transferred through the placenta to the baby. So I think in most cases, we're mostly worried about previous maternal exposure. And then obviously, once the baby's out, any exposure early in life. I'm not even sure, Jackson's 2.5 now. I don't even know that I had a lead test during pregnancy. So I'm not sure that we're testing pregnant mothers, actually. It's really at the point of birth, we check, and then we check, it's mandated to check at 1 and 2 during their pediatric screenings. Which is really when kids are on the floor, they're putting their hands in their mouth. It's when we know their exposure risk is highest.
So much of this, I think of Mr. Wimsatt's point. I mean, if we had things much more centralized, instead of 20 registries and waiting for, worrying about gaps in funding and, I just look at the work that we're trying to do to, the data we're trying to collect from many different places. And, it's in some instances it's there. It's just not necessarily readily accessible. But I agree, and I think, certainly some legislative action and those kinds of things, and recommendations that we make out of this commission can certainly help drive some change.
Yeah, I do want to reiterate what Dr. Laflamme said. It's a human resource issue as much as anything. I mean, we have claims data, we have hospital data, but then we have a part-time epidemiologist who can make sense of that data. So in a lot of cases, the data are there. It's really, we need the analytical power then to make sense of the data. And I think, those systems do exist really. And I don't know, Margaret, if you wanted to speak at all, but, electronic medical records are where this lives. And I think to Representative Soloway's point, in New Hampshire, we have kind of, those systems aren't super interoperable because of privacy reasons. In other states, those systems are moving towards a little bit more interoperability. Right, but we know, I think there are multiple vendors. So there are multiple systems, multiple electronic medical record systems within the state, rather than kind of one statewide system that all talks. And so I think it's sort of still in its infancy, maybe in New Hampshire, these kind of reporting systems that allow that interoperability. But I don't know a lot about electronic medical records. That's kind of my understanding. But we do have these other surveillance systems like claims, like hospital data, like birth defects registry. So,
Honorable Mesmer?
Yes, this discussion on lead reminded me that in the last session of this commission, we had come to the decision that we should get someone to come speak to us about lead in the schools, or at least the facilities, the drinking water issues, and the facilities themselves. I don't know if Katie knows anybody that could do that, but that would be something, because that does cover serum lead levels in children, but it doesn't look at all at drinking water exposure in schools, although I know there has been some sampling of lead in drinking water in schools. But also it might be a good idea to get an update on ventilation systems at the same time, since we're dealing with COVID. I don't know if there has been an evaluation in the SAUs across the state on ventilation issues, not with respect to lead, I'm talking about COVID now, but maybe both could happen at the same time.
Good point. I'm wondering maybe when Senator Sherman and Jenny are reaching out to the Department of Ed, maybe, we could have somebody, talking somebody about the special ed piece, and then somebody more about the buildings and, the ventilation and kind of issues. Ms. Tulio had your hand up.
Yes, I just wanted to respond, Katie, to your point. The the idea of the electronic medical record in its conceptual phase was a good one, but the problems ensued in that, just what you're talking about, there are so many different vendors. And so your large systems certainly have the ability to share information within the system, but it's not turned out to be an easy way to have collective data. And so in theory, it's a wonderful way to try and do it, but in reality, it's been somewhat of a disaster in terms of all the potential uses, at least in the study I've done of it.
Any other discussion? Well, seeing none, I think we have a lot of action items then from the last couple of meetings. One, we need to schedule the education subcommittee meeting. We're waiting to hear about this Department of Ed presentation. At the next, was it the next meeting we were going to talk about maybe looking at the membership of the subcommittees, because we have new members and they may be interested in joining us on the subcommittees. What else do we have? And then I know Senator Sherman had mentioned at one of the, I think it was our last meeting, he wanted us to look in at the education subcommittee, thinking about what we can develop for an environmental curriculum for CMEs, for physicians. That was one of his, one of the action items he left us for, and that's sort of the subcommittee meeting. But do you want, how are we going to come up with a date with that, Rep. Salloway? Are we?
I was going to ask Jenny Horgan,
Okay.
who is the master of this sort of thing, to help me schedule a meeting.
Okay, and then just notify us. That's great.
I do what
okay.
she tells me to do.
Okay, thank you. And I don't know, seeing nothing else on our agenda, I will entertain a motion to adjourn.
So moved.
Any seconds? Oh, Brett Mesmer, Honorable Mesmer, sorry. All right, well, thank you, everybody. It was
well done.
Yeah,
Thank you.
we gotta
So sorry, we have to take a roll.
take a roll call.
Yeah.
Oh, awesome. All right. We'll get my list of. All right, so I'm trying to go through who's I know is here. Representative Salloway.
Yes.
Dr. Bush.
Yes.
Ms. DiTullio.
Yes.
Honorable Mesmer.
Yes.
Ms. Costello.
Yes.
Mr. Wimsatt.
Yes.
Representative Nelson.
Yes.
Representative McMahon.
Yes.
Great. And Nancy Murphy. Yes. All right. Well, thank you, everybody.